Good morning, everyone. Today, we are going to discuss a topic about pre-medications. What is pre-medication? The drugs which are administered 1 to 2 hours before the induction of anesthesia, so as to make anesthesia safer for the patients. And it also ensure comfort to the patient and to minimize the adverse effects of anesthesia. Why pre-medications are given to the patients before the induction of anesthesia? Pre-medication relieves the anxiety of the patient. It also provides sedation to the patient to relieve pain, and it also provides amnesia for the pre-operative and the post-operative events. It also reduces the post-operative nausea and vomiting. It also reduces the risk of aspiration during the induction of anesthesia by decreasing the volume and increasing the pH of the gastric content. It also has an anti-sialolog effect. What is the anti-sialolog effect? The drugs which we are going to use for anti-sialolog effect is atropine, glycopyrrolate. These drugs reduces the secretions of saliva. It also provides a smooth induction of anesthesia, and it also reduces the requirement of anesthetic drugs intraoperatively. The factors to be considered before giving pre-medications. We have to assess the patient physical status, age of the patient, because in case of extremes of ages, the drug doses will be reduced or will be avoid giving sedation to the extremes of ages. And we have to assess the level of anxiety and pain of the patient, the type of surgeries. So, according to the duration of the surgery, according to the surgery type, whether it is a short procedure or long procedure, according to the type of surgery, we'll be giving pre-medications to the patient and the timing of the surgery. And we have to know whether the patient has any drug allergy or previously they have a frequent episodes of nausea, vomiting, all the histories we have to consider before giving pre-medications. First, we are going to see the about anxiety drugs and the sedation drugs. Okay. Sedation is ranging from minimum anxiolysis to a state of deep sedation, but not including general anesthesia. By giving a anxiety and sedative drug, it minimizes the discomfort, physical discomfort and pain to the patient. It also it controls the behavior, particularly movements of the patient, and it also minimizes the psychological disturbances and distress to the patient, and it also maximizes the potential for amnesia, and it also guards patient safety. The drugs used for sedations are benzodiazepines. In benzodiazepine groups, we'll be using diazepam, midazolam, lorazepam. Then comes the barbiturates. In that, phenobarbital is used as a sedative, and other drugs such as promethazine. The factors limiting giving sedative drugs are in case of extremes of ages will be limiting the sedative drugs to the extremes of age patients. And in case of head injury and in case of altered mental status and minimal cardiopulmonary reserve patients, in case of the patient is in a hypovolemic state and the patient who are in a full stomach. In all these cases, the sedative drugs which we are giving are reduced, the dose of the drugs are reduced, or will be avoiding giving the sedative drugs to all these patients. First, we are going to see about the benzodiazepine groups of drugs. Already we have discussed what are all the drugs we are going to be given in the benzodiazepine groups. That is midazolam, lorazepam, diazepam, and then alprazolam. First, we will see about the mechanism of actions of benzodiazepine. Benzodiazepine, when combines with the GABA A receptor, it increases the opening of the chloride ion and then it causes a hyperpolarization of the synaptic membrane and then it causes an anxiolysis, amnesia, and sedation. These drugs also minimally causes these drugs, the benzodiazepine drugs minimally affects the respiratory and the cardiac depressions. We'll discuss separately about each drugs, that is about midazolam, lorazepam, and diazepam. Okay. First, midazolam. Midazolam belongs to imidazole ring. It is a water-soluble drug. The dose of the midazolam is orally, it is 0.5 to 0.75 mg per kg. IV, it is 0.05 to 0.07 mg per kg. And IM, it is 0.07 to 0.1 mg per kg. Intranasally, it is given at the dose of 0.3 mg per kg. The onset of action is 30 to 60 seconds and the duration of action is 15 to 80 minutes. And the elimination half-life is 1.5 to 3.5 hours, 3.5 hours. Midazolam is mostly a causes a antigrade amnesic effect, which is a more potent than the sedative effects. Midazolam is a shorter acting drug when compared to a lorazepam and the diazepam. So the most common pre-medication which we are using in the intraoperatively is a midazolam as a pre-medication. The side effects of the midazolam is it inhibits the platelet aggregation by causing a conformational changes in the platelet membrane. And it also causes a ventilatory depression and apnea when the dose exceeds 0.15 mg per kg. It also causes a transient apnea in a geriatric patient and in case of COPD patient. This is about midazolam. Midazolam is a shorter acting drug which we use at the dose of 0.05 to 0.07 mg per kg. Next drug we are going to see about is the lorazepam. It is a poor lipid solubility. It is given at the dose of orally, it is 50 microgram per kg and IM at a dose of 0.03 to 0.05 mg per kg and IV it is given at the dose of 0.1 mg per kg. The onset of action is 1 to 2 minutes and the duration of action is 6 to 10 hours and the elimination half-life is 8 to 24 hours. It is 3 times more potent than other drugs and it also causes an antigrade amnesic effect and which is more potent than the sedative effects. The main side effects of lorazepam is it causes dizziness and ataxia. Next, we are going to see about diazepam. It is a highly lipid-soluble drug. It crosses the blood-brain barrier. It is given at a dose of, oral dose is 0.2 to 0.5 mg per kg. IM it is 0.25 mg per kg and IV it is 0.3 to 0.6 mg per kg. So the elimination half-life of this drug is 20 to 40 hours. So it has a longer duration of action. It has both sedative hypnosis and amnesic effect. The major side effects of diazepam is it causes a pain on injection and it also causes a allergic reaction and rashes. It also causes nausea, vomiting, and it also causes a abdominal pain. This is a flumazenil. Flumazenil is an antidote in the treatment of benzodiazepine overdose. So, the dose of flumazenil is 8 to 15 microgram per kg IV. The mechanism of action is it is a imidobenzodiazepine. It is a competitively inhibits a benzodiazepine at the GABA A receptor. The side effects of flumazenil is it may induce a seizure activity if the benzodiazepine have been given as an anticonvulsants. The flumazenil reversal following a midazolam ketamine anesthetic technique may increases the incidence of emergence, dysphoria, and hallucination. So these are all about the anxiety and the sedative drugs. Next, we are going to see how to reduce the post-operative nausea and vomiting. So we'll be for assessing the post-operative nausea and vomiting in the patient, we have a Huffel score, the risk factor for predicting the rate of post-operative nausea and vomiting according to the Huffel score. The risk factors are the female patients are more commonly affected in this, and non-smoker patients, history of previous post-operative nausea, vomiting, post-operative use of opioids, and the maximum possible score is 4 points. Each score, that is female, non-smoker, history of previous post-op nausea, vomiting, post-operative use of opioids. All these risk factors carries 1 point. So the maximum possible score is 4 points. So the risk of post-operative nausea vomiting percentage begins from 10% to 80% approximately. What are the other risk factor except the Huffel score is the anesthetic risk factor is use of volatile anesthetics, the use of nitrous oxide, the use of intraoperative and post-operative opioids. In the risk factors, the surgical risk factor also comes under the play. That is the duration of surgery. So each 30 minutes increase in the duration increases the post-operative nausea vomiting risk by 60%. So that a baseline risk of 10% is increased by 16% after 30 minutes. Then the type of surgery also comes to play in under the post-op nausea vomiting. So in case of laparoscopic surgery, in case of adult strabismus surgery, middle ear surgery, all these surgery increases the risk of post-op nausea and vomiting. So the drugs which we are used in the prophylaxis and the treatment of post-op nausea vomiting are 5-HT3 receptor antagonist, butyrophenone, dexamethasone, neurokinin 1 receptor antagonist, antihistamine, transdermal scopolamine may also be used, phenothiazine, and phenylethylamines. The most commonly used drug is a 5-HT3 receptor antagonist. The drugs come under this antagonist is ondansetron, granisetron, dolasetron, and palanosetron. The 5-HT3 receptors are useful antiemetics in the prophylaxis and the treatment of chemotherapy and radiotherapy induced nausea and vomiting. So the dose of ondansetron is most common drug which we are using daily is the ondansetron. The dose of the ondansetron is 0.15 mg per kg orally. Then IV is 0.05 to 0.15 mg per kg. It's used for prevention of post-op nausea vomiting in a dose of 4 mg IV in a children at a dose of 0.1 mg per kg up to 4 mg. The side effects of the drug is it causes headache, diarrhea, and causes slight prolongation of the QT interval. The next drug which we most commonly use is a prokinetic. In prokinetic, we are going to see about metoclopramide. Metoclopramide acts both centrally and peripherally. In peripherally, metoclopramide acts peripherally by increasing the lower esophageal sphincter tone, and it also speeds the gastric emptying, and it lowers the gastric fluid volume. In centrally, it acts by blocking the dopamine receptor in the chemoreceptor trigger zone of CNS to produces the antiemetic effect. For antiemetic effect, the dose is 1 to 2 mg per kg. In case to increase the lower esophageal sphincter tone, to speed up the gastric emptying and lower the gastric fluid volume, the dose is 0.15 to 0.25 mg per kg. The major side effects for the side effects of metoclopramide is it causes a abdominal cramping when we give a rapid IV injection. It also causes a extrapyramidal symptoms such as akathisia, tardive dyskinesia, and restlessness. It also causes hypotension, cardiac arrhythmia, periorbital edema, maculopapular rashes. The placental transfer of metoclopramide occurs rapidly, but the adverse fetal effects with a single dose does not have been observed. Other drugs which are used for reducing the post-op nausea vomiting is antihistamine, but we are not most commonly using nowadays. That is diphenhydramine and promethazine. The side effects of antihistamines are drowsiness, urinary retention. It causes dryness of the mouth and it also causes a blurred vision, and it also causes a extrapyramidal symptoms. The next drug is butyrophenol, that is droperidol, that is we are given at the dose of 0.625 to 1.25 mg. The side effects of the butyrophenol is it causes a QT prolongation, and it also causes a Taussig D pointers dysarrhythmia. Other group of drug is neurokinin 1 receptor antagonist. This neurokinin 1 receptor antagonist acts by inhibiting the substance P at the central and the peripheral receptors. The drugs which we are using in the NK1 receptor antagonist is aprepitant, which has been found to reduce the post-op nausea vomiting perioperatively, and it's additive with the ondansetron for this indication. So when we give a aprepitant, which will be given along with the ondansetron to reduce the post-operative nausea vomiting. Next, we are going to see about anti-sialox. What is an anti-sialox? It decreases the salivary and the mucosal gland secretions. So in anti-sialolog, we are going to use anticholinergic drugs. So what is anticholinergics? They are used as a anti-sialolog effects, and it also provides a sedative and amnesic effect, and it also causes a vagolytic effect. The drugs which we are used in anticholinergics are atropine, glycopyrrolate, and scopolamine. So we'll discuss the three drugs, that is atropine, glycopyrrolate, and scopolamine. So atropine is a shorter acting when compared to a glycopyrrolate, and atropine and scopolamine causes a blood-brain barrier, but the glycopyrrolate does not causes a blood-brain barrier effect. Atropine has a bronchodilator property, that is when compared to glycopyrrolate and scopolamine, atropine has a more bronchodilator property when compared to glycopyrrolate and scopolamine. Atropine also causes a tachycardia, then glycopyrrolate and scopolamine. Glycopyrrolate also causes tachycardia, but only 10 to 20 increase will be there. But atropine causes a increase in a tachycardic effect. Glycopyrrolate has a sedative effects when compared to a atropine. Scopolamine does not cause any sedative effects. Atropine has a lesser anticellulose effect when compared to other two drugs, that is glycopyrrolate and the scopolamine. So for glycopyrrolate effect, the most common drug which we are using is the glycopyrrolate. Glycopyrrolate, which is a longer acting drug when compared to atropine. So the dosage of each drug is atropine is given at the rate of 10 to 20 microgram per kg. Glycopyrrolate is given at the rate of 5 to 10 microgram per kg. Scopolamine is given at the rate of 0.3 to 0.4 mg. 4 mg. The scopolamine is available as a patches only. So intraoperatively, we are not using scopolamine, only atropine and glycopyrrolate we are using. So this anticholinergic drugs, that is atropine and scopolamine, causes a major side effects, that is it causes a central anticholinergic syndrome. The mechanism of action is the anticholinergic drug blocks the muscarinic cholinergic receptor and competitively inhibits the effect of acetylcholine in the CNS. So it causes a central cholinergic syndrome. So the effects are, it causes a restlessness, a delirium to unconscious to the patient. It also causes tachycardia, hypertension, it causes dry mouth, and it also causes a urinary retention. The treatment is cyclostigmine, which is an antidote which is given for the treatment of central anticholinergic syndrome. It's given at the dose of 0.01 mg to 0.03 mg per kg. Next, we are going to discuss about analgesia. Opioids, the most common analgesics we are used intraoperatively is opioids. Morphine and meperidine were historically most frequently used opioid for intramuscular preoperative medications. Sedative pain relief decreased requirement of anesthetic agent for the maintenance of anesthesia due to a synergistic effect. The drugs which we are used are fentanyl, pentazocine, buprenorphine, morphine, and pethidine. The intravenous dose of pethidine is 1 to 2 mg per kg. Pentazocine is 0.15 to 0.3 mg per kg. Buprenorphine is 0.3 to 0.6 mg per kg. Morphine is 0.1 mg per kg. Fentanyl is 1 to 2 microgram per kg. The major side effects of opioid is respiratory depression, nausea, vomiting, and causes a urinary retention and itching to the patients. Next, we are going to see about how to prevent aspiration. What is aspiration? Aspiration of 25 ml of volume at the pH of less than 2.5 will be sufficient to produce aspiration pneumonitis. The risk factors of aspiration is emergency surgery, inadequate anesthesia, abdominal pathology, obesity, opioid medication, neurologic deficit, lithotomy position, difficult intubation or airway reflex, and hiatal hernia. These are all the risk factors for causing aspiration to the patients. What are all the goals to reduce the aspiration risks? To reduce the gastric volume less than 25 ml, to increases the gastric pH that is more than 2.5, and it increases the gastric motility. So for reducing the risk of pulmonary aspiration, we are recommended a fasting guidelines. That is, for clear liquid, it's 2 hours. For breast milk, it is 4 hours. For infant formula milk, it is 6 hours. For non-human milk is 6 hours. And light meal is 6 hours. Fried food, fatty food or meat, it's 8 hours or more. This is a fasting guidelines we are following. So what are all the drugs, pharmacological intervention for reducing a risk of aspiration? That is, gastrointestinal stimulant is metoclopramide and cisapride. Already we have discussed about metoclopramide. It is a prokinetic. By peripherally acting, it reduces the gastric pH. Then is a gastric acid secretion blockers, that is H2 receptor antagonists, cimetidine, ranitidine, famotidine, and other H2 receptor antagonist is rosatidine, nasatidine, and gastrosipin. Proton pump inhibitors, omeprazole, lansoprazole. The other proton pump inhibitors are pantoprazole, rabeprazole. Antacids, which we are given pre-operatively, are sodium citrate, sodium bicarbonate, and magnesium trisilicate. Antiemetics, ondansetron, and then anticholinergics, atropine and glycopyrrolate. All these drugs reduces the risk of aspiration. The major complication for aspiration is a Mendelssohn syndrome. The first who described acute chemical aspiration pneumonitis. The patient considered at the risk for aspiration pneumonitis if the gastric volume exceeds 25 ml, that is 0.4 ml per kg, and pH is less than 2.5. The early signs includes cyanosis, tachycardia, massive pulmonary edema, bronchospasm, and hypotension. How to prevent Mendelssohn syndrome? The drugs given are sodium citrate, which is effective to elevate the gastric pH but not at reducing the gastric volume. Ranitidine, metoclopramide, and omeprazole. All these drugs prevent the Mendelssohn syndrome. So, use of Selix maneuver, that is giving a cricoid pressure to prevent a regurgitation in the patients. In case of full stomach patients or in case of laparoscopic surgeries. Now we are going to see about antacids. Antacids neutralizes the acid in the gastric content. Sodium citrate is commonly given before the induction of anesthesia to increases the gastric fluid pH prior to emergency operation. The dose of 0.3 m solution of sodium citrate bicitrate or polycitra, that is given 15 to 30 ml orally 15 to 30 minutes prior to induction. Next comes a H2 receptor antagonist, that is cimetidine, famotidine, nisatidine, and ranitidine. These agents competitively inhibit histamine binding to H2 receptor. It reduces the gastric acid and volume, and it also raises the gastric pH. The side effects is it rarely associates with hypotension, bradycardia, and arrhythmias, and cardiac arrest. Long-term cimetidine therapy includes hepatotoxicity. It elevates serum transaminase, interstitial nephritis. It elevates the serum creatinine, granulocytopenia, and thrombocytopenia. These are the side effects which occurs when we use a long term of cimetidine therapy. Proton pump inhibitors are omeprazole, lansoprazole, rabeprazole, esomeprazole, and pantoprazole. It binds to the proton pump of the parietal cells in the gastric mucosa and it inhibits the secretions of hydrogen ion. The side effects are nausea, vomiting, abdominal pain, constipation, and diarrhea. These are all the drugs which we are used for reducing the risk of aspiration. The drugs are proton pump inhibitors, H2 receptor antagonists, antacids. Most commonly we are using is a proton pump inhibitors. Next, we are going to see the pre-medication for pediatric patients. Patients without IV access, oral medications, oral pre-medication is useful to produce a parenteral separation, sedation, amnesia, and for a smoother induction. So, midazolam, it's given the route of orally, intranasally, intramuscularly, and rectally. So, oral dose of midazolam is 0.5 to 0.75 mg per kg. Onset within 30 minutes and the duration is 30 to 60 minutes. Intranasally, it's given at the dose of 0.2 to 0.3 mg per kg. It's a faster onset, but burning sensation is the main side effects in the intranasally. In case of uncooperative patient, intramuscular midazolam is given at a dose of 0.1 to 0.15 mg per kg. Rectal midazolam is also available at the dose of 0.5 to 1 mg per kg. Ketamine is an excellent analgesic and amnesic agent. So most commonly will be giving ketamine to the patients. The route is orally, intramuscularly and rectally. Oral dose is 5 to 10 mg per kg and IM dose is 5 to 10 mg per kg. The major side effects are oral, it increases the oral secretion pre-operatively and post-operatively. It causes a delirium to the patients. Opioids, fentanyl. The routes which we given are intravenously, oral transmucosal and intranasally. The dosage is, it is available as a lollipop form, the fentanyl is. So the dose is 5 to 15 microgram per kg. The oral dose is 10 to 15 microgram per kg. Intranasally is 2 microgram per kg. The disadvantages is it increases the gastric fluid volume and it also causes a respiratory depression in the patient, also causes nausea and vomiting to the babies, childs. There are some specific situations in which pre-medications are contraindicators. They are when the patient is predicted a difficult airway, that is difficult ventilation. In those cases, sedative pre-medications are contraindicated. In case of difficult intubation, where we cannot mask ventilate, where we cannot intubate, so in those conditions, we will be avoiding a sedation to the patients. Where there is an increased intracranial pressure in case of head injury patients, sedatives are contraindicated. In case of low cardiac output patient and in case of unstable hemodynamics, where the patient is in a hypovolemic state, where BPs are very low, unrecordable. In these patients, sedative pre-medications are contraindicated. So we'll be avoiding a sedation to all these patients. So conclusion is, pre-medication reduces the morbidity of surgeries. Pre-medication also increases the quality and decreases the cost of perioperative care to the patients. It returns the patient to desirable functioning as quickly as possible. Preoperative medication optimizes significantly and reduces the complications intraoperatively and postoperatively to the patients. Thank you.